Next start. Welcome everybody. Thank you for coming along. It's really good to have the next of these sessions, last of these sessions, I think, if I remember rightly. I introduced this idea of having a little showcase entree for new members of staff primarily, and Duncan is one of those. Duncan Stewart is a professor who joined our School of Social Professions. He's already making a splash as research lead, working closely with me at the university level, and I know working hard in that school, even though he's not met anybody personally yet, I'm guessing, unless he had the odd coffee when we were in that brief window of being open. Anyway, it's a great delight to welcome Duncan here. We're lucky to have him, and it's great to have him. And anyway, we're going to hear now for about 30 minutes or so about his current research and future research plans going forward, with a focus on improving the management of alcohol in primary care. Duncan's also going to probably more than touch on, but certainly touch on the problems and challenges of doing NHS-focused research at the moment. I can imagine that almost everything has been sidelined by COVID, not to mention being locked down and distanced and getting hold of data and other things. So looking forward to this. So Duncan, I'm going to open the floor to you. Duncan will talk for about half an hour, then we'll have plenty of time for questions. So thank you all once more, and in particular, thank you to you, Duncan. The floor is yours.
Thank you very much, Don. And can I just check you can hear me okay?
Really, really, really good connection.
Fantastic. I'm keeping my fingers crossed this time.
Yeah.
Thank you, everyone, for coming along. So I did a version of this a couple of months ago, and then I had a problem with my internet connection. So I've done it again. I've tweaked things a little bit. But I guess there's two halves to this talk, really. One is about, the first half is about alcohol and NHS policy. I want to give you a flavour of what it is about these things that I'm interested in. And the specific study that I'm going to talk about with community pharmacists is important to me at the moment. I'm doing this work, and it's got a few years to run. And in a way, it's foundational in terms of developing my kind of own research agenda moving forward. So you'll get a flavour of those two things, and you are more than welcome to pick it apart at the end. I don't mind at all, so be as critical as you want. There are going to be some themes to this. So when you talk about alcohol, entrenched attitudes and clinical practice are important dimensions to touch upon. Obviously, we are in the midst of a pandemic, and that is creating havoc within the NHS, both in terms of service delivery. So normal things, well, things that would normally be delivered and be going on in primary care and elsewhere are being paused, as is NHS research. And if that wasn't bad enough, all this has happened in the midst of a major reorganisation of primary care. So I'll spend a bit of time explaining the kind of the mess we're in and what that means for this specific programme of work and perhaps research more broadly. So let's start at the beginning. So why am I interested in alcohol? Well, you could describe alcohol as our favourite drug. I mean, this is sort of probably the central important message to give today, and it kind of underpins the research I'm going to talk about, and that will become very clear. But we do need to think about alcohol as a drug. So it's a psychoactive drug, it's a CNS depressant. Of course, we know it causes immense harm through intoxication, toxicity, so it is a toxic substance, and problems with addiction. And all of that is associated with an enormous burden of disease. Yet despite what we know about that, alcohol is clearly embedded in our culture. It's everywhere. Because it's such an important part of our culture and our economy, industry interests are everywhere. And the alcohol industry does tackle head-on public health messages about alcohol. So there is a kind of a policy battle going on in the background between sort of the public health contingent and the alcohol and the vested interest contingent And that creates all sorts of confusion and sort of mixed messages for the public. So it's hardly surprising that in this country, at least, we're not very good about talking about alcohol. And that isn't helped by stereotypical ideas about what alcohol-related problems actually mean. So, research and policy tends to focus on people at the severe end of the spectrum, people with the most problems, and overlooks the harms associated with alcohol use more broadly. So if there is a kind of foundational statement for the research I'm going to talk about, it's probably that we're probably looking in the wrong place if we really want to take alcohol and its related problems seriously. And we need to move beyond this stereotypical idea of the so-called alcoholic if we're really going to make a difference. So I probably don't need to dwell too much on what the health-related harms of alcohol are, but the important thing to convey is this: on the basis of current evidence, there is no safe level of drinking. So the relationship between the amount you drink and the amount of, or the risk of harm from your alcohol consumption is a linear one. So it's a dose-response relationship. The more you drink, the higher the risk. And indeed, there are over 200 health conditions associated, either directly or indirectly, with levels of alcohol consumption. But for younger people, in England, it's the leading risk factor for ill health and reduced life expectancy. It's the 5th leading risk factor overall for the population. And it's responsible for thousands of deaths per year, particularly amongst men. So one manifestation of this is the number of people that are admitted to hospital each year related to their alcohol consumption. So this, so that's over 1 million just in England a year. But this chart just gives you an idea of the kinds of conditions that we're talking about that are commonly associated with alcohol consumption. So it's not just liver disease, it's a whole range of conditions. And the real game changer in terms of our understanding of the health risks from alcohol is around cancer. And that was a big drive in the chief medical officer's reduction of the guidelines for risky drinking. So a few years ago, they were reduced to 14 units a week for men and for women. And that was driven to quite a large degree by a better understanding of how alcohol contributes to cancer. So I know this is all very depressing, but it is important. So we're all, just think about what I just said about focusing on problem drinkers. These issues affect everybody. Once they start consuming, 14 units. Doesn't sound a lot, but it does increase your risk of these kinds of diseases and conditions. So, the health burden and the burden, the broad economic burden of drinking is huge. It costs billions and billions of pounds. So in England, the costs of alcohol to society are around about 21 billion a year. A big chunk of GDP, and that's partly because so many people are drinking at or above the recommended limits for safe drinking. So over 10 million people in England alone are drinking above the recommended limits. That's an enormous number. It's hardly surprising that the burden associated with that is so huge. So it's all very well to sort of, pick up the problems associated with drinking, but what do we actually do about it? How do we go about reducing those alcohol harms? And here there's a bit of a dichotomy. As I said, the focus, research and policy and clinical practice is on the problem drinker, however that's defined. And and tends to ignore everybody else. But if we accept the dose response relationship between alcohol consumption and harm, then we actually need to start reconfiguring out the way we think about who should be the target of alcohol interventions. And in actual fact, when you look at the evidence in the round, the clear conclusion is that policies that focus on population levels of consumption are the most effective ones. So the Global Burden of Disease study is like the gold standard study of the state of our knowledge about alcohol and other diseases. And they conclude that actually reducing affordability through tax, price regulation, marketing regulation, and restricting availability are the things that are likely to have most impact on population level consumption. And that actually affects the consumption of not just problem drinkers, who probably, as you'd expect, are probably most price sensitive. So prices go up, and they're likely to be impacted more than people who are consuming less alcohol. But nevertheless, most drinkers actually change their drinking behaviour in some way or other. And this isn't surprising, because actually these are the kinds of things that have been implemented to reduce tobacco-related harms. Exactly the same kinds of approaches. It's interesting to speculate why we think about tobacco so differently to alcohol. But nevertheless, public health approaches that focus on the population as a whole do have a demonstrable impact on levels of consumption and therefore levels of alcohol harm. Now, at the individual level, so there's another dichotomy here. So you've got population level interventions and individual level interventions. And at individual levels, these brief interventions and treatment for alcohol problems do show some benefit, not just clinically, but in terms of economically as well. They represent a reasonable return for the investment. And the real problem with these individual level interventions, they're just not implemented on anywhere large enough a scale. So we know that the treatment system in the UK is on its knees. It's been dismantled, taken from the NHS, put in the private sector, and starved of funding. So it's just not up to the job. But nevertheless, it's the individual level intervention that I'm going to talk about today. But I thought it'd be useful to put it into the context of alcohol policy in general and the approaches to reducing harm for everybody, not just problem drinkers. So what do we know about alcohol interventions? Well, primary care, so the GP practice, is the key setting for delivering brief individual advice and counselling interventions, which is the most common, to reduce heavy alcohol consumption or problem drinking, however you describe it. Dependent drinkers, sort of 500,000 or so dependent drinkers in the country, probably about a fifth of those are actually in some sort of contact with a treatment service for dependent drinking. So the GP practice is always usually the first port of call for all of us when we're ill, and that's true of people with drinking problems as well. Now, there is a fairly large body of research literature which shows modest short-term reductions in drinking for these counselling style interventions. But the problem with the evidence is it doesn't actually tell us very much about how brief those interventions need to be, what precisely they entail, and what kinds of interventions work for particular types of people. The other thing about the existing literature is they tend to be efficacy trials. So done in sort of conditions that are kind of ideal for research, but not necessarily reflective of routine practice. So we don't know very much actually how well these kind of interventions would work if you just rolled them out and implemented them on a wide scale. That's partly because actually we know that GPs tend to miss opportunities to intervene with patients who have significant drinking problems. Very low levels of screening and intervention in general. So this is part of the problem. Primary care is the first port of call for people with drinking problems, but actually nothing much is actually going on in primary care to address alcohol, and certainly not in a systematic way. And the reasons for that, you're probably not surprised to hear. GPs are busy at the best of time. They don't have that much time in their minds to dedicate to discussions about alcohol with their patients. They also have kind of stigmatized attitudes that many of us do, and they find discussing alcohol with people difficult. I tend to avoid it. They also worry about the impacts of having discussions of sensitive topics like alcohol on the relationship they have with their patients, and actually feel they don't really have the kind of skills, training, background to be able to deliver interventions with any confidence. The linkage between general practice and other community support services is generally poor, and of course we need to acknowledge that there is sometimes a reluctance amongst patients to talk about alcohol or accept the fact that alcohol could be an important issue for their health. So it all adds up to a kind of a difficult situation in general practice, but alcohol is just going under the radar by and large. So we recently published this editorial in the BMJ, which just sort of brings all these kind of strands of thinking together, and really just making a very simple point that as long as the focus is on problem drinking, it really is just the tip of the iceberg. You're missing the bulk of alcohol-related harm. If you were to quantify it, you're missing the important bit in a sense. You're as the quote says, even small amounts of alcohol consumption are implicated in a wide range of health issues. And that usually goes unnoticed because people don't ask about it. They don't screen for alcohol consumption. It's not part of routine practice in primary care. And this really is a dysfunctional situation, because if you think about the scale of alcohol-related harm I talked about at the beginning, and the importance of population approaches and thinking beyond the problem drinker, that's a big thing to kind of unravel and sort out, and it actually is going to require a wholesale change to the way primary care is delivered, the way we think about alcohol and the place of alcohol within sort of the general practice consultation. So it's very much kind of sums up where we are in terms of the UK's problematic relation with alcohol. So, in terms of the NHS, the NHS long-term plan is kind of like the blueprint for service provision across the board for the next 10 years. And again, this is the primary NHS policy document. Everything else that's happening in the NHS flows from this. And yet, alcohol is again described in terms of problem drinkers. Actually, the only content really is focused on alcohol-related hospital admissions. So we know there are lots of them, but that's just the story doesn't end there. And it really is kind of missing the point. Is intervening after the damage is done, and much more thought needs to be given to alcohol prevention, particularly amongst people who are drinking at lower levels, who aren't identified as problem drinkers as such, because we actually need to focus more broadly on the wider risks to health from alcohol. So we made this point in another BMJ editorial, and we kind of contextualized it for a group of people for whom this issue of prevention, intervening early and broadening the discussion of alcohol away from problems and focusing more on health. And this is particularly important for older adults who are not only more susceptible to the effects of alcohol, but are also likely to have multiple chronic conditions. Now, we know that alcohol is going to be contributing to many of those conditions. In other words, alcohol will have some part to play in the fact that they're in the first place. But also, older adults with multi-morbidity, multiple long-term conditions, will be prescribed multiple drugs to manage those conditions. And alcohol interferes with the effects of many of those drugs. And so that, if there is a reason to integrate alcohol into discussions of health within the context of primary care, this kind of population would be the kind of a good place to start, a good bet for potentially demonstrating the effect of a concerted effort to prevent harm before it happens. So, the target population might look more like this rather than the kind of the problem drinker slumped on the sofa surrounded by bottles. And this is the kind of target population that's important to the study that I'm going to talk about in community pharmacy. And for my own research agenda, these are the sorts of people that I want to focus on in terms of developing interventions to prevent the harms from alcohol. So let me explain a bit more about that. I don't think it's a surprise that the older we get, the more health conditions we get. But if you look at GP practice records, by the time your practice population gets to around 65, so 65 plus, most of those people have more than one chronic condition. So they'll be multi-morbid. So, in other words, for older adults, it is the norm to have multiple chronic conditions. Now, interestingly, that age group are the ones that are more likely to be drinking at levels that are risking their health. So if you think about the recommended limits for drinking 14 units a week for men and women, this chart just shows it's the 65 plus groups, 65 to 74 for men and women, that are actually consuming the most. The greater proportion of those people are consuming alcohol above the recommended limits, and that's true also of the high risk limits. That's over 35 units for women, over 50 units for men. So these are the people who are drinking more. They're also the people with chronic conditions, and so they are putting themselves at risk directly in terms of their health and their relationship that has with alcohol consumption, but also really complicating the management of those conditions through prescription drugs. Now, even when you just look at people with long-term conditions, alcohol still increases the health risks. And we did this study. This is the first study to look at alcohol-related mortality, alcohol consumption and all-cause mortality, I should say, amongst people specifically with long-term conditions. And not only did it show that the more you drank, the higher the risk of premature death, even controlling for the range of conditions in the sample, those effects were magnified, amplified amongst people who smoked, people from regions of greater deprivation. So actually, the situation is complex, but alcohol is making things worse. Even when you control for people's range of conditions, and it's particularly so for people who are perhaps more vulnerable in terms of other risk factors for ill health and premature death. So that's the background to the research. That's where we're coming from. This is the research we're actually doing right now, and hopefully you'll be able to see how the two things are linked. So this program of research is a 5-year program funded by the National Institute for Health Research, and the aim is to co-produce with the pharmacy profession and with patients and evaluate in a definitive RCT an intervention that develops the health and wellbeing role of community pharmacies in relation to alcohol consumption, specifically within the context of established pharmaceutical services. Now, you heard me criticise the state of the evidence for brief interventions in general practice earlier. It's important to say that this is intended to be a pragmatic trial. So we're looking to develop an intervention and evaluate its effectiveness in real life. So not optimal conditions, but actually in the context of routine practice. The other thing that's important to emphasise is we're not asking practitioners to do something extra. This has been the typical approach to brief interventions for alcohol. So the GP has the consultation with the patient about whatever it is they've come to talk to them about, and then they talk about alcohol at the end. This is different. It's about actually integrating alcohol into the discussion and into the consultation, and talk about what that means for patients' health in the broadest sense. So it's in embedding the intervention into what pharmacists actually do already. It's important to say that this is a collaboration that's led by the University of York, involving practitioners, academic pharmacists, and people from a range of academic backgrounds from across the country, including patient representatives. And just to explain the co-production aspect to it. So it's co-produced within that research team, given the diverse backgrounds we have, and the NHS organisation that hosts the grants. So these kind of grants, the money goes to the NHS, and you choose a suitable organisation to manage the grant, and it gets contracted out to the academic team. But they have a really important role in terms of oversight of the study. It's co-produced with patient pharmacy advisory groups. So we have regular consultations with those groups, particularly important development of the intervention itself. And that would include workshops with those groups and patients and pharmacists beyond them. In liaison with other professional organisations, and in a number of linked intervention development studies. So that all adds up to a programme of stakeholder engagement. And the important thing about that is it actually occurred before, during, and it will occur after the programme. So the research is shaped by the people who will be delivering this kind of intervention and the recipients of it and related groups. Now, I'm sure you know what community pharmacy is, but actually it's interesting that most people have ready access to one. And that is the kind of the unique selling point of community pharmacy. You can just walk in and access healthcare. And it's not just dispensing, there are all sorts of public health and clinical services that pharmacists are now providing. And that includes provision of alcohol advice. Now, there's been one trial of a screening and brief intervention for alcohol in community pharmacy, and it found no significant impact on levels of alcohol consumption. So in this trial, they asked pharmacists to screen patients and then to deliver a kind of a 5-minute counselling session for those who were drinking above a certain limit, and it didn't make any impact on levels of consumption at all. The researchers also found really low levels of knowledge about alcohol amongst pharmacists, and they didn't really know very much about behaviour change and related issues with approaches to change people's behaviour. And probably most importantly, really variability in communication skills. They weren't actually very good at talking about alcohol. That's not unique to pharmacists. So our approach is to do something different. So we want to move away from this brief intervention as an additional component consultation, and to make it an embedded one. And the service that we wanted to embed our alcohol intervention into is medicine reviews. Now, I don't know if you've ever had one of these or been in a community pharmacy consultation room, but they are weird little tiny broom cupboards with a sink in the corner. Not the most conducive place for a consultation, but most pharmacies have one. And these medicine review services are contracted services. So the NHS pays pharmacists to do them, and there are targets, minimum targets to achieve. But they're very, very short. They tend to be described as a brief chat about your medicine, so patients don't often actually know what service they're actually getting. So they take the pharmacist at the word, they're having a chat, but actually it's a formal medicine review. They tend to be conducted in a kind of checklist fashion. So it's very much the pharmacist's agenda driving the consultation. The patient doesn't have much scope to kind of influence the direction of the consultation. And alcohol is not usually part of the discussion at all. And if it is, it's tacked on the end as kind of a lifestyle issue, again, as something extra, not integral to the discussion of medicines and health. But our intervention approach starts from the premise that alcohol is a drug. And actually, when you think about it in that way, pharmacists are probably very well placed to talk about it in the context of other drugs. In other words, the medicines that are being prescribed to patients. That's the thing that really appeals to pharmacists that we've worked with. Actually, they have that pharmaceutical knowledge is ideal for kind of having the kind of discussion with a patient about the medicines and how alcohol might be interfering with them. The approach is not about telling people to cut down. It's not about moralizing, telling people off, making people feel that they're doing something wrong. Rather, is to help patients think through whether drinking affects their medication use or indeed their health. So you're giving space to patients to set the agenda somewhat. And that needs to be tailored to the individual. So it's not a checklist. It's not kind of a routine form you can work through. It's tailored to the needs of the individual. So that could be a large discussion for some people, but more often than not, actually could be quite brief. So the way we've envisaged doing this is to develop a training intervention to help pharmacists engage with these issues with a focus on person-centred care, which means not setting the agenda yourself, but putting the patient and their needs centre stage. And that discussion should include alcohol. Now, we know that pharmacists and indeed many other healthcare practitioners aren't very good at having these kind of person-centred discussions for the kind of reasons I mentioned earlier in terms of barriers to implementation, and time is one really important one. Being suitably trained, having the level of skills to be able to have a kind of a consultation that isn't being driven by their own agenda. So that requires intervention with the pharmacist first. So that includes training and practice development, and also a lot of emphasis on person-centered consultation skills acquisition. So this is what the intervention that we've designed over a number, through iterative studies and consultations with our stakeholders, which we called the Medicines and Alcohol Consultation. So it's a 6-week program involving 2 practice development training days, focused on person-centered consultation skills, and sort of loosely based on motivational interviewing techniques, which involve helping practitioners resist the urge to tell people off, or to tell people how to stop drinking. Got to resist that. Instead, it's about understanding the perspective of the patient, listening to what the patient's telling you about their health and what concerns them, and empathizing and empowering the patient in terms of managing their own conditions as far as is possible. So they have these 2 training days, 3 weeks apart, and in between they have individually tailored weekly practice development support based upon recordings of the consultations they've done. And the idea is that the best way you learn about your practice is to be confronted with it. So it's interesting the way that when we did this, we were surprised by the degree to which practitioners, their recollections of consultations didn't quite match the reality of it. And so they might say, well, I was asking the patient open questions and listening to what they were saying. I wasn't pushing my own agenda, but that isn't what was happening. They may have wanted to have done that, but actually it wasn't quite reflective of the consultation itself. And it was only when you played back consultation, key bits of it, that actually the penny dropped, and they understood not only just where they were going wrong, but also the benefits of reflective practice became much more apparent. And so we developed quite close relationships with these pharmacists in the way we developed their practice, try to change their kind of bad habits to a degree, but also just actually trying to encourage them just to listen to what patients are telling them about their health. And it's only within that space, that framework, that alcohol can be introduced in a productive way, without it feeling stigmatized and sort of like being nagged or told off. And it allows the linkage with medicines and health to be made constructively. And there are some other elements to this intervention. So there was a kind of a paper-based guide, some web-based learning resources, and some peer support elements too. I'm looking at my watch, so I'm going to hurry up. Now after developing the intervention, we did a pilot trial, a sort of dummy run of the definitive trial. It was by and large successful, so we managed to implement the training program really successfully. We managed to recruit pharmacists for the trial. We managed to follow up all the patients that were recruited, 92%. But what we had problems with was recruitment of eligible patients. We didn't meet our target. And here we're beginning to get into the realms of the mess of the NHS. So halfway through our pilot trial, the community pharmacy contract changed, and the medicine use review, which is the primary service we were studying, there was announced it was going to be phased out, and actually pharmacists were already stopping doing them. So it was a bit of a disaster for us. And if that wasn't difficult enough, alongside of that, it was announced there was going to be a major reorganisation of primary care. So these medicine use reviews are going to be replaced by a different type of medicine review, but it was going to be done in general practices by a new workforce of clinical pharmacists. And all that was going to be happening within about 6 months. And so on the basis of the service we were studying was going to be phased out, and actually the whole organisation of medicine use reviews or medicine reviews in the NHS was going to change, we had to conclude that a definitive trial of this intervention in community pharmacy just wasn't possible. So it left us in a bit of a bind, and so we decided to actually roll with the change, and persuaded NIHR, our funder, that actually we could do this study, this program of research in the new setting, in primary care, in general practice, with this new medicine review intervention. And so we kind of concluded the best way to manage change is to study it, and they kind of agreed with us. So essentially, to cut a long story short, we've had to relocate the intervention into primary care. It's a different context, with pharmacists, but these are new pharmacists recruited by and large from community pharmacy, but not exclusively so, in a new role. And that whole process has required further co-production. It's going to require refinements of the intervention, some more feasibility work and preparation for a trial. So everything is up in the air. And all this happened just before the pandemic kicked in. Now, underpinning the kind of the change to the way that medicine reviews are being done, primary care networks have kind of become the main sort of, structural organisation to primary care in England. So you have groups of practices working together to share resources, I guess, and to make care more interconnected. That's the general drift of it. And this was, mooted in the long-term plan, and it's got many merits to it, but the problem is it all happened rather too quickly, in our opinion. It's just been a huge overhaul, financially, structurally, the way GPs work with each other and different services. There's been a whole lot of confusion and about the implementation of it, the funding of it, the contracts involved, and plus COVID-19. The whole thing has just become a real mess. So while the NHS has been dismantled over the last 10, 15, 20 years, we've had fragmentation of service delivery. Now all of a sudden, practices are being asked to cooperate, but you can't just make that happen overnight. They haven't been able to recruit new pharmacists as quickly as they'd have liked, and of course, building new relationships takes time. Ordinarily, it certainly is not going to happen over 6 months, which is what the time scale for this change involved. For the structured medicine review itself, the thing that we want to study now, that was delayed by COVID. So it's going to be in April last year, delayed to October. And actually, the specification for it was only published about a fortnight before the service itself was supposed to be implemented. So practitioners didn't really know what they were supposed to be doing. Now, the good news for us that up to that September publication, had been no mention of alcohol in it at all, and we were building ourselves up to making the case that there ought to be. And then all of a sudden, out of the blue, it actually acknowledged the specification, acknowledged the risk of interactions with medicines from alcohol, and actually had some content about practitioners encouraging patients to think about that alcohol consumption in the context of the SMR. But unfortunately, it recommends screening and brief advice, the old approach that we know doesn't work. And so it's kind of given us an enhanced reason. It's just gone down well with NIHR actually, but suddenly alcohol's appeared into the picture, we're well placed to study it. So it's done us a favour in a perverse way, and kind of builds upon the rationale for doing the programme and developing this intervention. So this is where we are now. In fact, we were discussing it only yesterday. So field work has stopped and start during the pandemic. It's paused again now. We can't do anything. At a time where things were changing on a massive scale in the NHS anyway, and the NHS under huge strain, as we all know. And we're beginning to see just how complex and varied the implementation of primary care networks and the new ways of working between pharmacists and GPs, etc., is actually panning out. So actually, we're having to sort of amend the research again as we're going, because the problem is, what kind of service are we actually going to end up evaluating? We don't want to be evaluating a COVID service, a service that's been impacted by COVID in various ways. We actually want to be researching practice as usual. And what is that now? Is it ever going to go back to how it was before? Or are we now going to have to get used to the idea of telephone and Zoom consultations? This is all up in the air, and it makes planning a research program very, very difficult. But nevertheless, we continue to be optimistic that we'll be able to do our trial in the end, but it's just going to take a bit longer. So the concluding slide, you'll be glad to hear. So I think we look at the evidence, we look at the research we're doing or trying to do. It's clear that factors associated with alcohol are complex and interact. It's not a simple picture. But for us, the important thing is alcohol makes managing health problems much, much more difficult. So that's the rationale for doing this program of research and others like it. So we need much smarter ways of exploring the contribution of alcohol to the presenting problems of patients in primary care. This intervention is one example, but actually there could be many others, and it's the many others that are kind of an important part of my research plan moving forwards.